what can we control within our four walls and with the budget that we got and the people we got and the beds we got, and how can we do that differently? And so we got some support to get some experts. I mean, I'm no expert in a lot of this stuff. And we made some huge changes when we cut our wait times in half. We actually did that by getting rid of beds. We kind of looked around to see what best practice was. We put, again, a customer focus on it. I've always thought that the more horizontal you are, the more of a patient you are, the more vertical you are, the more of a customer you are.
Hello, everyone, and thank you for listening to another episode of our podcast. Today, I'm joined by Dr. Drew Digney, Medical Director at Oceanside Health Centre under Vancouver Island Health Authority. Drew is an emergency physician, a medical director, and is the founder of the Yana Motion Clinic, where he leads the integration of advanced 3D markerless motion capture technology to improve patient mobility. He's a man on a mission to drive fundamental changes both within the healthcare system and externally. Drew, thank you for chatting with me today. I'm really excited to have this talk. Before we dive into the episode, could you tell us a bit about yourself?
Absolutely. And first of all, thanks very much for having me. Ohad, it's a pleasure. Happy to take the time. Yeah, I've had an interesting journey. So I started off my career as a full service family physician in Prince George, which for those listeners who don't know where it is, it's in the middle of BC. It means it's a 10-hour drive from any major center. It's only halfway up the province, but it's quite isolated. And I spent 7 years there, which were fantastic years in just really cutting my teeth in my early career, because you could do anything there because everybody needed anything and there was very few folks. So that was, so I did emergency. So I got started in emergency medicine, was there. I did full service family physician. I had caught babies, had my pager back then for 7 years, and then decided that was just a lot. Trying to keep up on everything was a bit of a challenge. And so made the move to emergency medicine, challenged the qualifying exam. And then we made a move back home. I originally grew up in Vancouver, missed the ocean smell. And so my wife and I came back and ended up on beautiful Vancouver Island. And I've been here since the turn of the century, I guess you can say that now, and started full service emergency medicine in Nanaimo. Over time, evolved into a number of administrative hats. That really came out of frustration. I'm the first physician in my family. I came from a family of entrepreneurs, and it just drove me crazy looking at the lack of customer service that we provided. And I thought there's got to be a better way of doing this. And so rather than getting mad, I thought, well, I'll just roll up my sleeves and get involved and I tried the getting mad part, and actually had the chief of staff sit me down and question whether I wanted to continue to work in the hospital at one point, not here, but elsewhere. And so that made me, as a young physician, think that's probably not the best strategy, because they weren't talking about the problem I was upset about. They were talking about me. So I realized that I actually needed to get the conversation back onto the right thing, which was the problems that we faced and how we were going to fix them. So I thought, okay, I got to work from within and try and make those changes. So that's led to an interesting 20 odd years of being involved in a number of different hats, as you outlined. Right now, my present hat is the medical director up in Oceanside, but I really had the opportunity to get to understand the system as it is, as the executive medical director within Island Health. And again, for your listeners, that is a large part of the British Columbia, the provincial healthcare system. We manage about 1 million and a bit people. It's got about a $2.3 billion budget, and really are looking after virtually all of the healthcare needs for that population. So I got to sit at the executive table for about 5 years and thought, well, this is where we can make change to really make things happen. And that didn't quite work out the way I'd hoped. Now I'm back where I think I can make the most change to the most people doing the medical director role. And then the other two startups are, I'm twitchy, I'm an emerge physician, I get kind of bored. And these were two opportunities to make some change on a small level. It's not going to make the kind of system change that we need, but they're interesting and they're new and they're exciting. And it's amazing in a private sector how quickly you can do things. So it kind of takes me back to my family roots of the entrepreneurship. They're both private companies, and that's been a lot of fun and a lot of work, but a lot of fun, because you can actually get things done and get it done pretty quickly. So,
well, there's a lot to unpack there, Drew. Let's maybe kind of start with your roots in family practice, family medicine. I find a lot of people that have sat in your chair here on this show talk about those years doing family medicine as really all-encompassing. Like, it's very interesting how the scope of practice is so broad when you're in a rural community or relatively rural community like Prince George.
Yeah.
What drew you into medicine to start with?
Again, my family, we ran a bowling alley. So that's my background. So my Sunday night job was to, take the customers, other shoes, give them their bowling shoes, take them back, spray the disinfectant in it, make sure the numbers all lined up. So that's kind of my background was seeing that kind of entrepreneurship and family business. I was always good at sciences, in high school. I kind of ended up going to Queens because I had a bunch of friends that were going there, and it seemed like fun to go across the country to somewhere totally different. So that took me there. I never was one of these, I always want to be a doctor kind of people. It was just kind of fell into it. And I thought, well, I got to pick something here. And they had a thing called life sciences, and life sciences turned out to be one of these degrees that really didn't go anywhere. It was sort of a stepping stone to something. So it was full of people that were either wanted to go into medicine or dentistry or physio or all these kind of things. And after a year of that, I really actually thought, oh man, this is not for me. It was actually quite cutthroat, and it was a bit of it was an interesting dynamic. And I thought, I'm not really sure this is where I want to go and what I want to do. So then I went and started doing like biology because I kind of enjoyed biology, and then actually did a poli-sci minor, which was always messed my professors' heads up when I was talking about the other things that I had to do. And then I had to do a thesis. So unfortunately, it was at a university that had a very heavy plant biology focus at Queens. So I went to one of the animal biologists and said, look, there's a lot of xylem and phloem here. And I kind of I'm not really into plants. Like, is there something I can do, that would be in an animal type model? And there wasn't very many labs that really could take students. So he kind of said, well, leave it with me. And then I met with him a week later and said, well, I got a buddy that works in the hospital, who does research there. Would that interest you? And I thought, yeah, okay, that would be cool. So off I went as a little fourth year student down to the hospital and started doing surgery on, rabbits, and working with the docs there doing their primary research. And then they took me on rounds and took me around, and I kind of thought, hey, this actually would be a really cool job. So that kind of prompted me to pull up my socks because I got fairly involved in the politics there, which my marks had dropped a little bit. Then thought, well, let's give it a go, right? What's the worst that can happen is I don't get in. And then I didn't get in. So I thought, okay, now, no, if you're not going to, now you've really set me the challenge. So anyway, I had to do a little bit of work and got into
it. Sounds like that's one way to get you motivated, is to set a challenge.
Yeah,
also.
tell me I can't do something.
Exactly. Also, I think there's a strong thread here of really being multifaceted. It sounds like you always have a few interests on the go. So you decide to go into medicine. You end up in Prince George.
Yeah.
What was that like then, kind of running this full service family medicine business?
I've reflected a few times how different it is now from then in just one career, like one, from the time I started. So I long in the tooth. So I started before there was a residency in family medicine. We had the rotating internship, and everyone went off and did their 1 year after medical school, and then went off, and usually most people did locums, and then you kind of figured out what you wanted to do, and then you go back and do a residency. So that really changed right around that time in the early 90s, certainly in British Columbia. So where you really had to start making decisions early. And I think that's a shame, to be honest, because I think it was an awesome sort of experience to get out there and
to get kind of really more broad exposure before you can.
Yeah. What's it like? What's the lifestyle like? All these kind of things that do influence how we work. So the other thing, as I've looked at why we have this primary care crisis is, when I came out, if you're a generalist, you went out and you did locums or you opened an office. There was no other option. So you couldn't go and be a hospitalist. You couldn't go work in a walk-in clinic. There were no walk-in clinics were not around then. You couldn't go to sports medicine. You weren't a palliative care doc. So all of these avenues that are now open to a generalist were not really there. They're certainly in their infancy, or some people sort of had a family practice and did more sports medicine, but they didn't say, I'm a sports medicine doc, and took referrals from other primary care providers. Mm-hmm. And that's really changed over the last 20, 30 years. So, I did everything. I did palliative care. I went and assisted with my patients if they had surgery. So, the surgeons would call us and say, hey, your patient's getting their hip replaced, in 3 weeks. And I'd rearrange my office and go and assist, because that was fantastic. So when they came to see me 2 weeks later, I go, yeah, I know exactly what happened in there. I was there, because I saw your hip, So all of that has really changed. Very few family docs do those kind of things. And
so is some of that like subspecialization that's emerging, drawing people away from kind of being that frontline triage doctor that is then directing the care, kind of quarterbacking the care from that point on, like you were doing early in your career?
Yeah, and even Emerge. In Prince George, when I got there were no full-time Emerge docs, and that was a 40,000 visit department. That's considered a pretty big department. Everyone had a practice, so what's happened there is it's docs have pulled out of their work in the acute care for all sorts of, and none of this is bad or no one's done anything, with a malicious intent. It's just happened over time. But it kind of helps explain why I think some of where we are today and our primary care crisis that we have. We haven't kept up with some of the demographic changes that have occurred, but just that change in how people work, the length of time it takes to get your ability to hang up your shingle and go out there and work. So now it's 2 years minimum for family medicine. There's a lot of people do a third year in other things. They'll do half and half stuff. So we've really had a change where the generalist per se, the true generalists that went out and did everything, they're gone. Like there's very, very few, unless you're in a very, very remote place. Before, that was kind of more the norm.
Yeah, maybe that's a good segue then into kind of the next phase in your career where you talked about you decided to be part of the solution, not just be frustrated with the problem, and moved more into administration as you moved into
Sure.
Vancouver Island Health.
Yeah.
And so what's that been like, right? And you still manage a clinical practice as well, right? So it sounds like
Yes.
you're kind of have a lot of balls in the air of still doing clinical practice while also serving the other side as an administrator. What's that experience like?
It's been a combination of big high fives and thumbs up when something's, when something works, and learning patience. I learned the healthcare system moves, the old adage, glacially. It's very slow, which as an emergency physician is a challenge. It started off by managing the emergency department, and that was, again, sort of saying, there's a better way to do this. Like, this is crazy what was happening. And the kind of delays and how long it was taking to get to people, and the way it was organized, and the way we flow people through the department, and all sorts of different things. And I could kind of see a different way of doing that. And thought, well, the only way to do that is to step up and just do it. And I've been lucky because I've had excellent co-leads, administrative co-leads with me. I've had some great leaders that have actually listened and helped, make things happen rather than kind of I find sometimes in healthcare, the first thing people do is try and find all the problems that could happen, and then sort of get paralyzed by that because there's a great fear of making something worse. And I'm often thought, how could it be worse? And that innovation, that sense of trying. And I had an amazing group of physicians and nurses, and, we were at a pretty bad place. People were calling our hospital Nairobi General, in a very derogatory way. And I kind of went home one day and thought, I don't want to work in Nairobi General. Like I want to have pride in where I work. I want to have pride in, I want people to come up to me and say, man, I had a really great experience in the emerge. It was awesome. So that's kind of when I kind of went with the group and said, is this really where we want to work? We're the face of that. If you're saying we're Nairobi General, then that's us, right? So how do we change that? There's stuff we own, and so let's stop worrying about what the government isn't doing. Let's stop worrying about administration isn't doing. What can we control within our four walls, and with the budget that we got, and the people we got, and the beds we got, and how can we do that differently? And so we got some support to get some experts. I mean, I'm no expert in a lot of this stuff, and we made some huge changes when we cut our wait times in half. We actually did that by getting rid of beds. We kind of looked around to see what best practice was. We put, again, a customer focus on it. I've always thought that the more horizontal you are, the more of a patient you are, the more vertical you are, the more of a customer you are.
A great way to phrase that.
And we're really good at paying attention to a lot of the horizontal people, but the vertical people, we have to pay attention to them because they're the ones that'll walk up and say, well, how long is it going to be? And can I get a blanket? And, do I need to put more parking in? And every time that happens, it actually delays the care to the horizontal people because it means a nurse is answering that question. They're going to get the blanket. Whereas if they're at home, if you got them out of there, then they don't need a blanket anymore. So that whole interaction, that whole interruption, it's all gone. And there's amazing science on interruptions and what they do and flow and how to manage that volume of people. So it really was kind of taking rather than in the moment, what's sitting in front of me as the leader, I kind of stepped back and said, okay, we got 140 people or 120 or 100, whatever it was at the time. How do we do that? Like, what's the smartest way to do that over the course of 24 hours? And it was just little changes over time. So that was really fantastic. Like to actually see that, to see it, I'm a number graph guy. So to see that graph go from 3-hour wait for our level 3s to, 1.1 hour wait on average to see a physician was fantastic. More importantly was to see the calls, our security calls dropped by 95%.
Wow.
Like it was crazy. And that was just an unexpected consequence, right? That wasn't the intention, but people don't come to the emergency department on the whole, for the most part, angry. We generally make them angry by what we do or what we don't do or how we treat them or the information we don't give them. So our code whites, as we call them, dropped like precipitously. It was crazy.
I really like one thing you said about, not allowing yourself to be overwhelmed by the degree of the challenges, right? I mean, healthcare is so big. It feels like it's such a big part of all of our lives. It's such a big part of our country's GDP, of any country's GDP.
Yeah.
And so when you kind of step back and say all the things that have to get done are so overwhelming, how, as an administrator, as a clinician in my domain, can I drive change? And I think that's such an important perspective of kind of recognizing that like perfect is the enemy of progress. And that it sounds like you made some choices on saying, hey, let's focus on a few key areas and maybe even one metric, which is wait time, which will have a downstream effect on both patients and clinicians and everyone's satisfaction. So I think that's a very good takeaway for our listeners, many of which are leaders within healthcare systems, to think about how to challenge this kind of how to overcome this challenge of like being overwhelmed and saying, I'm going to start to fix it one thing at a time and start with what matters most and keep a real clear focus on a measure that will let us know that we're progressing towards a better end state. Is that fair to say?
Absolutely. Yeah, no, I think, and that's where you get, because otherwise you get very frustrated, right? It's, it's a funny place. You come in, you put your head down, you work hard for 8 hours and you look up and it looks exactly the same as when you walked in the door. It's not like there's an inbox that gets smaller, but people just keep coming in. And I remember when we moved to our new department, we opened at 5:00 in the morning, we moved everything over, and then the first patient walks through the door and I said, well, that's the last time this place will ever be empty. It's it until we turn the lights off here and move somewhere else. Like it's a 24-hour roadshow. So, and then that piece led me to the higher sort of executive, organizational piece, because at some point we really did everything we could to really get squeaky clean on what we were doing. But we had all these inpatients that, like every emergency department, that were kind of clogging up our ability to do our job because they weren't moving out of the department and, all these kind of things. So that's when I kind of made a plea to the health authority around some changes and some ideas I had. And of course, they turned around and offered me a job. So that was an interesting part of my career, that five or 6 years there. So.
And so you had a real view from kind of front line in the trenches, and then you probably had a broader perspective as an executive.
Yeah.
Maybe just summarize for us, what do you think are the bigger challenges today? I mean, we talked about some of the outcomes like wait times, or the fact that it's very hard to get primary care now. But if you really step back, kind of what are the top 2 or 3 challenges that truly we face as healthcare, maybe specifically here in Canada? But I think that probably most of what you'll be talking about is broadly applicable to our listeners from other countries like the US or other jurisdictions.
Yeah, I would say, and not very specific, but it's demographic access and accountability. So I think those are the big 3. So the demographic is something that we're just facing. So I have a few patients go, the government should have blah, blah, blah. And the government couldn't have seen kind of what's happening. So the demographics are changing at both ends. So we have the greatest population of 80 and 90-year-olds walking around on the planet than we've ever had. They're making a bigger percentage of the population. We are doing a fantastic job of pushing out that longevity curve. The hard truth is the death rate hasn't changed. It's still 1 per person. So everyone gets something at the end that takes them off the planet. And usually they're going to come in contact with the healthcare system. So I can remember to talk, somebody was telling me about how healthy they were and that we're healthy, we're doing all these great things. And I kind of said, well, no, that's actually really bad. The most efficient taxpayer we have, and being a publicly funded system in Canada, is that taxpayer that drives a really expensive gas guzzling car, because that puts lots of taxes. They drink and they smoke, because those are very highly taxed things. And then the day after they retire, they just have a big coronary and die in their Cheerios, having breakfast, because then they won't take anything out of the healthcare system. And the healthcare system accounts for 40% of revenues in Canada. So, as horrible as that sounds, that's the efficient taxpayer. Put it all in, take nothing out. But that's not what we do, right? We put it in, and then for another now 30 years, we take out. And we do it by getting our knees replaced, our hips replaced, our cataracts done, having a couple stents put in there, getting our diabetes managed, maybe ending up in the CCU, getting our stroke thrombolized. So, and then coming in with a bazillion meds, and then now maybe getting a melanoma. Now you're going to be on, people used to die from a lot of those things. We have amazing treatments for cancer now. One of the challenges I had in my role was we were running out of chemo spaces because people were living for 10 or 15 years with some of the newer therapies that are available, which is fantastic. But all of this stuff was never there before. So all of these things sort of conspire on the demographic side. And at the other side, we've got a young population. So all the docs are retiring. So I'm the last baby boomer. I'm 64. And we've got the younger group coming up behind us. And rightly or wrongly, they're just not going to work the way our generation did. So I'm noticing, and there's no science to this, but that it's taking 2 and sometimes 3 physicians to take the same size of practice as my colleagues that are retiring from family practice.
Because they have a different view on work-life balance, or
totally.
the complexity of care is increased. So they have to more subspecialization, more attention.
Yeah, all of those, and they're all legit, right? They're totally legit. I'm not saying and they want to spend time with their family. Oh, that's okay, right? There's nothing wrong with that. I mean, I wish maybe I'd taken a bit more of that and, back there, because the kids go really quick. So that's happening though at the same time as what's going
on both ends, and it's kind of pulling in opposite directions, right? So
2 ends.
Are there, like, with population growth, or generally, are there more physicians coming into the workforce, or do you think that the role that medicine plays in people's career choices is also diminishing?
Good question. I don't have our data. I think we are having more, but the bigger question is, what is that career span? So how many hours of time are we getting out of that person coming out of med school today?
Right.
How many hours of direct patient care is being delivered? And I don't have the data on that. I don't know. My suspicion is it's less, right? Mm-hmm. Because they're not on call all the time. I mean, when I joked about Prince George, literally when I was in Prince George, I never turned my pager off, right? I was always available for that baby, right? I was always on, right? So
I mean, that's really well explained. So that's kind of point number one, is demographic shift.
Yeah, demographics.
Older population, living longer, needing more care, more complexity. And then on the bottom end, changes in the productivity of the physician community. So what's number 2?
Access. So we have a huge access problem. So we're still running our system as if it was 1970 or 1980. On the acute care side, if somebody said to me, maybe you asked me later, and when I was doing the access and flow thing, I pushed really hard. There is really good evidence that if you come in with certain conditions on a Thursday or Friday into an acute care hospital, pretty much anywhere on the planet, you will have a different outcome than if you come in on a Monday or Tuesday. Mm-hmm. So in my mind, that's unconscionable. How do we have a system that is in its design giving different care to people on the toss of the dice as to whether it's a Monday or Tuesday when they have their AAA rupture, right? So, but that is because of this thing called a weekend. So a weekend is something that if you look at the hospitals, you can tell what day of the week it is by looking at the parking lot. So because there's not as many people there on a Saturday, Sunday, there is on a Monday to Friday. An example is one of our main hospitals in Vancouver Island. There are 12 PTs available, physiotherapists on a Monday to Tuesday, and we got 3 on Saturday or Sunday. So what we create in healthcare, because most of what comes into acute care hospitals is coming through the emergency department. So about 85 to 90% of hospital admissions are coming through Emerge. I work in Emerge. You can't tell what day of the week it is in there because the door is always open and they're always coming in at virtually the same rate. There's some little variations from day to day, but effectively it's the same rate. And we don't output them at the same rate. So somebody that gets admitted, on a Friday is going to have a very different experience of their first 2 days in hospital than that person on a Monday. And then we don't do things like we block the output on a Saturday, Sunday, because the long-term carers don't accept patients coming out on a Saturday or Sunday. So one of the things that I've advocated for is we need smoothing, right? We already spend enough money in healthcare that we don't have a revenue problem. We have an expenditure problem, but we have lots and lots of money. But I'm not saying bump up Saturday or Sunday. What I would love to see is, what would an acute care hospital look like if we smoothed? So if you couldn't tell what day of the week it was. So if you took those 12 physios and those 3 physios and made it 9 physios every day, traffic jams start. There's lots of research, operational research that will tell you about how things get jammed up. And the way they get jammed up is you touch your brakes. There's always open road in the front.
That lumpiness, exactly. Whether it's on the roads or in the healthcare system, is access also an issue between urban and rural? Also, as that starts to change, I've heard that as well.
Yeah, absolutely. I think the really big problems are access right now is acute care. So that being able to get in, because the emergency departments are jammed, and they're jammed because the hospital's full, not because they can't manage it. So that's a myth that I hear all the time. Well, if we can get all these people, if we can build a walk-in clinic and they can go there, nice try. That's not going to work. There's an interesting paper that looked that by diverting one admission, so not admitting one person that you would otherwise admit, is the same as diverting 70 walkie-talkie patients. the money is, and the way you're going to get efficiency is you got to figure out how to make sure you're just admitting the right people. So that excess piece is sort of rural, urban, but that's not going to fix the system per se, you know. And then family physicians, like the lack of family physicians now is critical. Like that is got to be the biggest. I just can't believe how bad it is right now. In the last 3 days working in the urgent emergent ED, I mean, it's more like a small ED, but I'm diagnosing cancer, and anybody listening as a nurse physician will probably understand. I'm diagnosing cancer primarily, not seeing the complications of cancer, but diagnosing cancer more and more in an urgent.
Which doesn't belong in the ED. That belongs in family practice. That belongs much earlier on.
Oh yeah. This is stuff people had a cough for 6 months. This is another, like, these are not things that like just came up today, right? So this is stuff, and they can't get in to see their family physician, or they don't have one. So they leave it. It's terrible. So that access is really going to hammer our system, because we're not going to catch things early. People are not getting the preventative maintenance. I mean, the person that like recently looks like they had colon cancer hadn't had their basic screening done because they hadn't had a family doctor in 5 years. You know, that kind of stuff it's going to bite us. It's just going to cost way more, and the patient outcomes are going to be so much worse. So those two things, I think, if we can get hospitals operating like they should be, which is being customer focused. If you got your front doors open 24/7, then you got to have your back doors open 24/7, right? And that's, you know, everything, the operating rooms.
Avoid those extreme peaks and valleys and invest more in prevention, more in early triage,
absolutely,
quarterbacking through primary care. And just before we jump into solutions, what's the third point and kind of what you see as the main problem areas?
In accountability. We don't have a revenue, certainly not in Canada. I don't believe we have a revenue problem. So I think we have an expenditure problem. So we're already spending 40% of on average, our provincial budgets. You tell me we're going to find any more money without not paving roads or not having schools or not, you know, all those other things need to happen. Our health authority gets $2.3 billion with a B dollars every year. It's a staggeringly large amount of money. We got billionaires now, so we throw that number around, but it's put into perspective for me. So the difference between $1 million and $1 billion is, if I asked you to start counting, they just start counting and count to $1 million, and you did it every second, right? It would take you 11 days of just sitting there to get to $1 million. To get to $1 billion, it would take you 11 years. $2.3 billion is a huge amount of money. And I think we can do a much, much better job with that, but there's very little accountability, right? So there's a lot of duplication and stuff that happens. We're not really tight with how we spend our money. So that's a big problem. And I would say the other big problem is variation in practice with physicians. So I'm going to hold myself and my colleagues accountable for that. There's a massive variation in practice that we don't appreciate because we don't measure it.
Because of accreditation, or because?
No, it's just, so I started looking at things and I kind of got interested in this within my department, because I thought, why? And first of all, it was patients per hour. So I wanted to see the productivity of the docs, because that obviously has an impact on the wait times and everything else. So we had a pretty big variation in practice, right? In how quickly docs work. And that's not a good thing or a bad thing. It was just what it was, right? So, but I used it for scheduling, right? Because I thought, well, I'm not going to put all the slow docs on the same day and all the fast docs on the same day. That makes no sense. So that's how that sort of piece of data, but that got me interested in giving them other pieces of data. So we started looking at CT rates. So there was a 7-fold difference at the rate at which physicians
will refer out, physicians refer.
Well, 7-fold difference, right? That's enormous. And then I started reading about it. So, you know, there's hospitals, I think it was a Calgary study looking at what happened if you came in with a renal stone. Well, one hospital had twice the rate of operative fix on that versus a conservative fix. Twice. Like, how does that happen? So we have about a 3-fold difference in the rate of admission. As I mentioned, that admission to hospital is such an important metric for patients, but also just for the whole system. But we have a variation of 3 times between what one doc does when people come in the door and what another doc does, without any apparent difference in outcomes. So, you know, I looked at bounce back rates, because of course the docs all said to me, oh, you know, all his patients come back and I end up admitting, right? And that just wasn't the case. There's very little variation in the rate at which patients came back.
I guess the real point behind accountability, though, is knowing what the actions are. You listed a lot of actions: referral to CT, deciding to operate, deciding to bring a patient in as an inpatient. But I guess the ultimate measure is the outcome, right? So can you correlate that to the outcome? To doctors that have more CT referrals or less inpatient stays, do they get a better or worse outcome?
there's a sweet spot. So that curve is a bit of a U. So there is time you can do too much, right? Yeah. So you can order too many tests, you can do too many investigations, because all of those things often come. If you start doing then biopsies on people, or you start putting dye into them, or you start giving them things because you found something that you might not have otherwise found if you hadn't done that, but actually it's nothing that needs anything further, you actually start causing harm. So there's some good studies in the States looking at sort of these quartiles of how much money gets spent on people. And the top quartile that actually has a worse outcome than those ones in the middle. So there is a sweet spot in this. So, and there shouldn't be that much variation, right? Like there is basically one textbook that everyone uses when they study for their emergency exams called Tintinelli. And there isn't 7 different ways of doing things in there, right? Here's how we do it. But somewhere along the line, we start doing things very, very differently, but we don't know it because we don't talk about it. So it was interesting when I started presenting this data where people would then start on shift, like some of the higher or even the lowers would say, ooh, what would you do in this? It started a really interesting conversation about how people were practicing and looking at their practice, because we get very, very little feedback on those kind of metrics about our practice in comparison to others. And I think that's a shame. That's something that in this day and age, with the amount of data that's collected and the amount of information that's out there, that doesn't get brought back, right?
That's maybe a great segue, Drew, into talking more about solutions. I know that when the US started its shift to what it's calling accountable care, the big stake that it made was adoption of electronic health records, because it ultimately said, what we need is data. In order to be accountable, in order to hold the system or the clinicians accountable, they need to know what the outcome was. And the outcome's only evident if you can actually track the longitudinal data of the record. Is that a truism? Do you think that data is one of the keys to getting less variability in practice and more accountability?
So that's the caveat, right? We've gone to an electronic health record in Island Health. So as long as what's going in is accurate and useful, then yeah, it is. I mean, if in an ideal world, if all the best data was put in, it's great. But a lot of physicians go, I'm not a data clerk. Like that's not my job. There was one doc that, for whatever reason, he would put in his diagnosis sort of verbally, like in his note, but in the structured place where you put it in, he just put general symptoms every single time because he just said, that's not my job. So is this sort of way of making a bit of a point around that? And it takes time. Like doing what I've seen is, and again, not necessarily back. I mean, you would not have been able to read my notes. I'm telling you, my handwritten notes, they were terrible. So now you can at least read what I've said, but it takes me a lot longer. So I've actually, one of my little innovations recently is I just went ahead and hired my own scribe, which in the States they'll go, so what? That's very unusual in Canada, to actually sit there in the room with me and write down what the patient was saying, rather than me listening or writing it down at the same time and then going out of the room and dictating it afterwards. It was great. Like it worked exceptionally well. It was a fantastic experiment. And I can see where, one technological tool that I really hope we're going to incorporate, and I've tried to get us as a test site, is AI scribing, artificial intelligence. And I know the products are out there. I've played with them. I think they're ready for prime time, but that will save a huge amount of time, right?
To both the patient interaction and then minimize charting after the fact, which I know is a big issue for primary care in particular.
Yeah. And that's the HR issue though, right? When you bring this in, that's one thing, we've noticed. Yes, you're going to get good data, but the downside is your physician productivity is definitely, decreased. Now it's decreased because they're producing better notes, right? For sure, than some of what was there, and some of what I still see in handwritten areas. They're not great. For some reason, docs tend to be a bit more verbose and add more information when it's in that format. I don't know why. I've got some macros, we call them, so they're kind of standard templates. And I've actually had people say, oh, you can't do that. That's cheating, kind of thing. And I'm going, well, wait a minute. Your old notes used to say chest with a tick mark next to it, right? Meaning the chest was normal, right? Like a check or a little N with a circle around it was kind of notation that we had. I said, how is that not cheating? Like you never even said what you actually did. You just said check. And then later you could tell me that was anything you wanted, right? So at least, mine, of course, I can't just put anything. I have to actually put what I actually did. It's really, really been interesting to watch the mindset change between what happens when I got a pen in my hand versus I've got a microphone in my hand. So,
and again, I think to your point, AI can help us structure that a little differently, again, if done right. Maybe as we move on to talk a bit about technology, you know that I'm an imaging geek. Is there a role also for medical imaging for us in the vendor community, whether it's through handheld ultrasound or other imaging solutions that can also help to overcome these three profound challenges that you laid out that we're all facing in healthcare?
Yeah, I mean, I think, certainly I've lived through the handheld and bedside ultrasound, which was never there, and lived through the fight, that emergency physicians could actually use a bedside ultrasound. That took a while to get through that piece, to get acceptance of that. I mean, that certainly has been amazingly helpful. It allows us to sort of make some of those decisions earlier about getting people either stay or go. I mean, the ultimate decision for emergency physicians, do they stay or do they go? So, if I can rule out that ectopic pregnancy, or at least know there's an intrauterine pregnancy, at 2:00 in the morning, I don't have ultrasound available to me, that's for the patient, that's fantastic.
By eliminating the legacy referral pattern, by saying, I'm going to send you out to radiology, we'll wait for the exam to come back. That's not good for the patient. It's not good for the system.
Yeah. So there's some of that. I mean, again, not my area of expertise, but I think AI in radiology is potentially going to be a game changer. We've got something that's already digitized. It can't be that hard to teach it what a normal chest x-ray looks like, which if you look at most radiology tests, most of them are normal. Like, we're doing a lot of ruling out things. So that hopefully will save, the radiologist a lot of time, because I once we get comfortable with it, the AI is only going to push abnormals. Like, that's I would see that as the first step, right?
That still is facing, though, a large regulatory hurdle. Like, having been the CEO of an AI company, yet today, AI, both by Health Canada, FDA, all the other regulatory bodies, is only cleared for what's called computer-aided diagnostics, meaning it's not yet cleared for a rule-out. It's not yet, the regulator is not comfortable to say the only one who's going to look at this chest film is going to be the AI, and they're going to rule out if it's they'll only flag the abnormals.
It will take time, and that will happen. I mean, we still hear about the Tesla that killed somebody, right?
Right. The one.
We don't hear about the other, 10,000, in other cars that killed someone that day, right?
Right.
So that's human nature, right? We tend to go, I mean, healthcare, come on, we're still using fax machines, for goodness sakes, right? Like, my industry is the last, right? I 100% of my referrals still go by fax. So we're really slow to pick up on new technology, let me tell you. So it's that's one I tried to get rid of the fax machine, but I failed on that one too. But it'll come, like, that's going to come. And not even on a tech side, but Canada in particular, and again, your American listeners may be a bit horrified. I mean, we need to get on the mid-level provider bandwagon fast. We and BC, I'm very impressed, has very quickly said, okay, yeah, we're going to have physician assistants. Yes, we're going to have associate physicians. The penny dropped for me when I actually took my cat in to see my vet, and there's my vet doing an exam on my cat, talking through the exam, and their assistant is putting the computer system, and I'm going, what's wrong with this? Like, what? Why am I?
Why can't I do this in human medicine?
Right? Like, what's going on? Like, how come I have to go out and into a microphone? So that we could solve, we have a physician crisis even in emergency medicine. We can't get enough docs to fill the shifts we got. Well, give me a scribe and we're done. Like, that will solve that problem, because the productivity, and I know there's data says it's 10%. My productivity went up 20% when I had a scribe. And that wasn't even in an ideal situation. It was a very less than ideal situation. And I was killing it. It was fantastic. And what I found about it is I could think better too. Like, I wasn't, I could concentrate on what I needed to think about next, not rehash what I just done. And so there's so much we can do, right?
That is certainly a topic that I've had some experience with here on the vendor side. When we, at other companies I've worked at, when we first launched virtual care services, we staffed them with nurse practitioners who have a scope of practice that's very comparable in many ways to a primary care physician, much more accessible, have more time for bedside, have more time for having the right conversation, and then have, a second tier primary care doc behind. Same thing as actually we're seeing in ultrasound, where, it's moving from just being handled by a physician, but rather nurses, nurse practitioners, physician assistants in the US, all these kind of allied health professions are bringing more advanced imaging modalities earlier in the care process, and they're disseminating, kind of democratizing some of that, which to your point is eliminating some of the bottlenecks that we're seeing in this physician world. And I think it's something the US is doing maybe more progressively than Canada at this point.
Yeah, I think for sure it is. And I think part of that is, again, getting back to the accountability is, in a system where you need to generate some revenue, it is somewhat, again, I'm not an expert in the American system, but it certainly appears to me from the outside, there's a revenue generation piece there, right? Like you're trying to, so efficiency is really important. And I've always argued that, well, efficiency is just as important in a non-revenue base, because we have a responsibility and an accountability to spend that 40% of our BC budget responsibly, right? That $2.3 billion we get, we need to make sure that every single penny of that is appropriately allocated and spent appropriately, right? All of the same arguments that say, well, if it's good for a revenue generating model should be the same for a non-revenue generating model, because what it means is you're going to be more efficient, which means you're going to actually be able to do more with the dollars that you have.
I'm watching the clock, Drew. I know we're almost at time, and actually we didn't get to one important part of your career. Maybe just briefly tell us a little bit about your involvement in these two very interesting sounding startups, Yana Motion Clinic and OptiMind.
I'll start with OptiMind. It's RTMS, which is repetitive transcranial magnetic stimulation, which some listeners may or may not know, but I won't spend the time telling you what it's all about. But I had a friend of mine who's not a physician come to me and ask me to help them with this. And they started telling me what it was about, and it's got magnets in it. And I kind of turned her down. And then, so can I just pick your brain? Because we worked on a board together. Then I went back and I started Googling it and reading about it. And I was shocked that I didn't know anything about it. So this is a technology that's been around for years. It's been approved by Health Canada since 2012, I think. It's an unbelievably good treatment for depression, among other things. But that really is its main focus at this point. But I think it's going to be an exploding field for what this tool can be done. And essentially, it's a machine that can externally stimulate very focused parts of the brain without having to put anything through the skull. It uses electromagnetism principles to actually put a big magnet sort of on the outside of the head, create a quick magnetic field, which creates an electrical field, which then passes on the other side of the skull and creates a stimulus.
I have never heard of this technology.
I know, it's very cool. As you can see, I got pretty excited about it. So I said, and then I realized it wasn't available. So here's this, and the data says the treatment is excellent for treatment-resistant depression. So I thought, and we had a mutual friend whose son had terrible depression. And I thought, this is not right, that there's this treatment that's available that is not covered, but nobody's doing it. So anyway, long story short, as I helped her, and we have a clinic running in Victoria and have had some fantastic results on that. So that's been exciting to see the ability to bring something that's just sitting there, make it available for people that to access it. I mean, it's still not covered, although it's been recommended to be covered. But even then, I think, we need to, it needs to be available for people. Like, at least people need to have the option, the choice, whether they would like to come and get it. And then my other baby, as part of my executive medical director hat, I was down in Kansas City. I just saw some people doing some really fun stuff, and it was 3D motionless capture. So markerless capture. So this is getting away from the ping pong balls and the funny suits and all that kind of stuff. And so fast forward 8 years, working with a Canadian-based company via markerless, we've kind of put a package together to say, you've got a really good tool in here that generates fantastic data. But the challenge is having a cost-effective way of capturing that data, getting it in a position that your software can then do something with it. But more importantly, how do you present that information to people in a way that they can then use it? So I kind of say this is the stethoscope of the musculoskeletal system. I mean, right now, the tool we mostly use for looking at people, musculoskeletal system, is our eyes. Our eyes are terrible. They're not very good at that, although people will believe they are. The evidence would speak otherwise. And this tool is fantastic. So you can walk in what you're wearing right now. And in about 5 minutes, I can tell you pretty much everything about how you walk in an objective, reproducible, and fast and accurate.
So this is gait, physical therapy, rehab, all of that.
Anything to do with movement, sports. You just want to get better, back to work, back to school. Is that the implications for this are, I say it's bringing an objective measure. And again, I think my thread through my career is objectivity, data. Let's understand something. So this brings data to movement in a way that has never been there before. And I think we can democratize it. I think we can get it to a point where anybody can get this, and it'll be the same as getting to know your CDC or whether you're 20/20 vision or 20/40 vision or whatever. Like, it's just going to bring that objectivity that I think we need. So that we're just launching commercially now. So it's taken a long time to get it all the pieces in place. The pandemic was a bit of a kick in the pants, but we managed to ride that out. But it's been fantastic working with these really bright engineers and really smart people, and just sort of throwing a vision out there and watching them problem solve. It's totally different working with engineers, boy, because they go straight to, okay, here, you got the problem. I've got 4 solutions. Let's figure out the best one, rather than here's my problem, and then somebody brings you up 6 more problems while your solution to your problem isn't, going to work. So
tell you what, Drew, I feel we should have you back on the show just to talk about those 2 startups, because they're fascinating and certainly very novel. But we are going to need to wrap today. So much of what you talked about resonated with me and really got me excited. And I love your energy, and I love your impatience to not wait for everything to be resolved, but let's focus on what we can change now. If our listeners want to keep up with you and learn more about what you're doing, is there anywhere they can go to get more information?
I do have a LinkedIn page. I must admit it's stale because I just don't have time. I'm the last of the boomers. So this whole social media thing is, probably I should be better at that. But I think probably if people start messaging me through LinkedIn, that's a good place, or an email. Certainly happy to give you my work email, and that works as well. So.
Yeah, we can post that in the show notes. Drew, such a pleasure to have you today. I really enjoyed our conversation. Let's keep in touch.
Sure, absolutely. Thank you very much. It's been a pleasure chatting, and hopefully maybe somebody will take one of these ideas and run with it and make some changes in their own environment. So it'll be great.
Great. And to all of our listeners, thank you for joining us for another episode of our podcast. We'll be in touch. Over and out. Bye-bye.